Today's grand round speaker, Dr. Katharine Clapham, who is currently an assistant professor in the Division of Cardiovascular Medicine at the University of Utah. And she initially obtained her bachelor's in biochemical sciences from Harvard College in 2008 and an MD from the Harvard HST Joint MIT program at Harvard Medical School. And then she went on to complete her residency in internal medicine at MGH in Boston and went on to complete her fellowship in cardiology at the Yale New Haven Hospital in 2018. And so while she was at Yale, Dr. Clapham developed a keen interest in pulmonary vascular disease while working in the vascular biology lab, leading her to pursue further training via the Burke Advanced Fellowship in Pulmonary Heart Disease at Brigham and Women's Hospital in Boston, where she completed it in 2022. And so Dr. Clapham currently serves as a co-director of the Pulmonary Hypertension and Dyspnea program at the University of Utah. And we're all excited to hear her grand rounds today. So please join me in welcoming Dr. Clapham, who will be delivering her talk titled Updates in Pulmonary Hypertension.
Great, thank you so much for the introduction. And thanks for the invitation to be here to talk to you. I do have a couple of disclosures which aren't relevant to the current presentation, but these are they. And I'm going to be focused on talking about, at the beginning, kind of the diagnosis, the most recent hemodynamic definition and clinical classifications of pulmonary hypertension, treatments for PAH, and then I want to spend a good amount of time also talking about methamphetamine-associated pulmonary arterial hypertension, which is a clinical issue that we see a lot at University of Utah, and I think you also have at your institution too. So be curious to hear people's thoughts on how to manage this clinical issue. So pulmonary hypertension is a hemodynamic definition, but that simply describes that the pulmonary arterial pressure is elevated, but the treatment for pulmonary hypertension is really centered on what the driver of that elevated pressure is. And so we think 5 different groups of pulmonary hypertension, so 5 different causes of elevated pulmonary artery pressures. And you're probably familiar with the WHO groups. Group 1 is pulmonary arterial hypertension, which can be idiopathic or heritable or related to connective tissue disease, and methamphetamine PAH also falls in this category. And this is a rare disease, but it gets a lot of airtime, and it's the disease that we treat with pulmonary vasodilators. It's much more common to have pulmonary hypertension from left heart disease or from lung disease, but people have tried to look at whether pulmonary vasodilators can be helpful in this scenario, and the majority of the evidence really suggests that they're not. And the underlying treatment, the main treatment, is treatment of the underlying condition, so treatment of left heart disease or treatment of lung disease. I'm not going to spend much time talking about chronic thromboembolic pulmonary hypertension, which is rare. It has a distinct treatment pathway. You have an expert already on that topic at your institution, Dr. Chanik. And then Group 5 PH is kind of a grab bag of different types of pulmonary hypertension caused by diseases that we don't fully understand the mechanism by which they cause pulmonary hypertension. So that's hematologic disorders and systemic diseases like sarcoidosis. And a lot of these patients come to our attention because they've had an echocardiogram that shows they have an elevated TR velocity and an elevated estimated pulmonary artery systolic pressure. And so this table comes from the most recent set of guidelines published in 2022, suggesting that if the TR velocity is very elevated over 3.4, we should start wondering about PAH or CTEPH or significant precapillary pulmonary hypertension. But I do want to also point out that the guidelines incorporate a couple of other factors, including the presence of other echo signs of pulmonary hypertension, and then risk factors or associated conditions for PH or CTEPH. So if someone has a history of connective tissue disease, or they have a history of congenital heart disease, if they have a family history of PAH or blood clots, all those things should raise your suspicion for one of these conditions. So the TR velocity, the estimated PSP really has to be interpreted in context. And even though the echo is a really nice screening tool for this condition, the correlation between the non-invasively measured pulmonary artery systolic pressure and invasively measured pressure on right heart cath is really not very good. So this data comes from Stuart Rich at Northwestern, where they looked at the estimated PSP correlation with right heart cath measures, and you can see there's quite a spread. So most people are within 20 millimeters of mercury of the invasively measured value, but some are up to almost 40 millimeters of mercury. So there's the absolute number is not that reliable for estimating what the invasively measured number will be. And this is just another example of a similar finding from the REVEAL registry, which is a large registry of pulmonary hypertension patients, showing that the blue dots are patients who had an echo that estimated their PASP as being 10 millimeters higher than that on right heart cath, and the red ones are 10 millimeters below. So again, quite a spread. But the higher we make the tricuspid velocity, regurgitant velocity cutoff, the more specific we get for finding pre-capillary pulmonary hypertension. So this is a receiver operator characteristic curve for TR velocity and how that correlates with patients who had a mean PA pressure of above 20 and a PVR of above 2 Woods units. And so you can see the cutoff of 3.4 is pretty specific, although you lose some sensitivity the higher cutoff you use. And then, as I mentioned, we need to be in tune with the other echo features that can point us in the direction of the diagnosis. So other features of significant precapillary pulmonary hypertension, including PAH or CTEPH, are things like right ventricular enlargement, so the RV being bigger than the LV, flattening of the interventricular septum. Or we can also look at this TABC over SPAP ratio, which gets to the idea of right ventricular function related to afterload, and if that's low and more consistent with RV dysfunction, that's more consistent with significant precapillary disease. People have also described that the pulse wave Doppler in the RVOT can have mid-systolic notching. So that's kind of a characteristic finding of significantly elevated pulmonary vascular resistance. The PA can be dilated. Again, not a specific sign, but another clue. And then signs of elevated right atrial pressure on echo are also useful. So if the IVC is dilated, doesn't collapse, or if the RA is dilated, those are all sort of supportive signs that there's significant precapillary pulmonary hypertension. So this is an example of a person with precapillary PH, their echo on the right, and you can see that the RV is enlarged. It looks bigger than the LV, and that is in contrast to someone who has pulmonary hypertension related to HFpEF, where you can see they have left atrial dilation, they might have left ventricular hypertrophy, they might have tissue Doppler velocities that are more consistent with diastolic dysfunction. So you can use your contextual clues to kind of think about what the likely etiology of the pulmonary hypertension is here. And I think it's important to make the point that we talk a lot about the pulmonary arterial pressure and the pulmonary vascular resistance, but ultimately pulmonary hypertension is also a disease of the right ventricle, and the right ventricle has to work against an increased afterload. Initially, it tries to compensate by hypertrophying and dilating, but ultimately, at the end stage of the disease, it's unable to keep up with the metabolic demand, and ultimately the right ventricle fails, which is the cause of death for most of our patients. And this is another illustration of that concept. So here we're looking at the survival of patients with a high PVR. Both of these PVRs are high, but higher PVR and lower PVR. So in the red is a PVR of greater than 650 and blue PVR less than 650 dynes. And so the survival of patients with the higher PVR is worse. In the middle is patients with more preserved right ventricular ejection fraction of a greater than 35 in the blue and less than 35 in the red. And so survival again is worse if you have right ventricular dysfunction. And then all the way on the right, you can see that when we further stratify patients, those who have a low right ventricular ejection fraction, so the elevated or not. So the right ventricle is a really important, right ventricular function is a really important prognosticator in pulmonary hypertension. For diagnosis ultimately is right heart catheterization. And a lot of time has been spent trying to figure out what is a normal pulmonary artery pressure. And this study published by Kovacs in 2016 looked at over 1,000 healthy subjects and measured their mean pulmonary artery pressure supine and at rest. And the average was 14 plus or minus a standard deviation of 3. So using this, the upper limit of normal is about 20 millimeters of mercury. And not only is that, above normal by what's average, but mean pulmonary artery pressure of above 20 is also associated with increased mortality. And this is just one example of such a study, but this is a study of about 20,000 vets, retrospective study by Dr. Marin, who's at the University of Maryland, and shows again that there's an inflection point at about 20 millimeters of mercury for the mean pulmonary artery pressure in terms of mortality. And this is one of several studies showing a similar finding. And as I mentioned, we really want to think about where the driver of that elevated pulmonary artery pressure is coming from. Probably in that veteran population, a lot of that was not precapillary. And that where the driver is really what dictates how we treat the problem. So precapillary on the arterial side is things like pulmonary arterial hypertension and CTEPH, lung disease, and then postcapillary PH refers to pulmonary venous hypertension from elevated left-sided pressure, so elevated LVEDP or left atrial pressure. So all that together has led to the most recent definition for what is pulmonary hypertension. So again, if the mean PA pressure is above 20, we consider that significant. And we consider it to be precapillary if the wedge is less than 15. And even though a wedge of 15 is not normal from registry data, we think that this cutoff is pretty reasonable for distinguishing pre and post capillary pH. There's a population that has just post capillary, so just heart failure from left heart disease. Treatment is diuresis and treatment of have other concomitant conditions that cause precapillary pH. Or it can also include people who have had longstanding elevated pulmonary venous pressure, elevated pulmonary vascular resistance. And people have often wondered about how to best treat these patients, whether maybe they should be treated with pulmonary vasodilators. But again, the majority of evidence suggests that pulmonary vasodilators are probably not helpful for most of these patients. And the most recent guidelines also put together a definition for what counts as exercise-induced pulmonary hypertension, because all of our PA pressures go up during exercise because our cardiac output increases. But some people have an increase in their pulmonary artery pressure that's out of proportion to the increase in their cardiac output. And that can be like HFpEF, or that can be precapillary pH as well. And so they gave that a definition and said if your change in your PA pressure was greater over the ratio of the change in PA pressure over the change in the cardiac output pressure, cardiac output was greater than 3, then that was abnormal. So as I mentioned, pulmonary arterial hypertension, we talk a lot about it, but it's rare. The estimated prevalence is 15 to 50 cases per million. And worldwide, the most common cause of PAH is schistosomiasis, but not in the United States. So here we mostly see patients who have idiopathic PAH or connective tissue disease-related PAH are the two most common. And then as I mentioned, I'm going to spend some time talking about that in our part of the country. We also have a great deal of toxin-mediated PAH from methamphetamine use. And even though these are sort of heterogeneous conditions that lead to pulmonary arterial hypertension, congenital heart disease or connective tissue disease, methamphetamine are all pretty different. But they are characterized by a similar vascular remodeling that takes place, which includes growth of endothelial cells and smooth muscle cells and fibroblasts in the arterial side of the pulmonary vasculature. And ultimately, this leads to narrowing of the lumen of the artery and then platelet activation, and ultimately sometimes just obliteration of the distal blood vessels. The survival of patients with pulmonary arterial hypertension, we estimate registries that were done in the early 2000s at 3 years is around 75%, so still room for improvement. And the first therapy that really made a huge difference in the care of patients with PAH was continuous intravenous epoprostenol, which is a prostacyclin. And this study was published in 1996, and they had patients with class 3, New York Heart Association class 3 or 4 symptoms, so very functionally limited patients that they randomized, they treated with EPO or conventional therapy, which at the time was diuretics and digoxin and Coumadin, and showed that patients with who were treated with epoprostenol had a much better survival than those who did not receive it over the period of 3 months. So this was the first really game-changing treatment available for PAH. And it's really, prostacyclin analogs remain the only therapy that's ever shown a mortality benefit in PAH. None of the other drugs have been studied that way, in part because it's a rare disease and it's hard to study that way. So the current therapies that exist for pulmonary hypertension target 3 main molecular pathways. The first is the endothelin pathway. So endothelin receptor antagonists like ambrisentan, bosentan, macitentan help reduce vasoconstriction and proliferation of smooth muscle cells in the blood vessels. Then we also have PDE5 inhibitors and soluble guanylate cyclase stimulators, which both target the nitric oxide pathway through different mechanisms. PDE5 inhibitors prevent the breakdown of cyclic GMP to GMP, and soluble guanylate cyclase stimulators promote the formation of cyclic GMP from GDP. And both of these work through the increasing of cyclic GMP in the cell to improve vasodilation and also have an anti-proliferative effect. And finally, the prostacyclin pathway, as I mentioned, we use prostacyclin analogs, and they can be given intravenously, they can be given subcutaneously, continuously, or in inhaled form, or there's also oral form, slightly different mechanism of action, but there's a receptor agonist in that pathway called selexipag. And the other landmark trial in the pulmonary hypertension space, therapeutic space, was the AMBITION trial, which showed that initial combination events. It was a composite endpoint of death, hospitalization, or disease progression. So it's recommended now that we start people on combination therapy upfront. And people than 2. And so this was the Triton study that was published in JACC a couple of years ago, where they looked at whether starting people on an ERA, a PDE5, and selexipag, which targets the prostacyclin pathway, was better than dual therapy. And actually, this did not show any significant difference in their outcome of events, and also no difference in PVR or 6-minute walk distance. So standard kind of remains to do the 2 therapies up front. And even though pulmonary vasodilators haven't really been studied in a way where we're looking for mortality, I would say that meta-analyses of studies that have been done suggest that there is a signal towards increased survival, and anecdotally, I think people who care for patients with PAH would also agree that patients live longer now in the modern era of pulmonary vasodilator therapy. So we've definitely come a long way since the 90s. And there's an exciting new therapy that's available in pulmonary arterial hypertension that I wanted to mention. The basis for the development of that therapy came out of the understanding that patients who have heritable PAH, the majority of them have mutations in BMPR2. And so 80% of patients with heritable PAH have mutations in BMPR2, and 20% of patients with sporadic PAH have mutations in that gene as well. And then a number of other genes have subsequently been identified that are involved, but many implicate the SMAD, transcription factors, and downstream signaling from there. So based on this knowledge, there was, a lot of work done in preclinical studies with mice and rats, and that led to this model where we think that in PAH there's an imbalance of BMP and TGF beta signaling. And so people who have PAH are deficient in BMP signaling. And so BMP signaling broadly we think of as being kind of anti-proliferative, and TGF beta signaling broadly we think of being pro-proliferative. And so people developed this new molecule or it's an antibody that binds activins and GDF molecules. And so it acts as a ligand sink for the activin receptor and rebalances these anti-proliferative and pro-proliferative signaling. That's the concept. And the results have been pretty exciting. So the PULSAR trial was a 24-week study of patients already on some kind of pulmonary hypertension background therapy who received sotatercept, which is a subQ injection every several weeks, and found that they had an improvement in their pulmonary vascular resistance, as well as in their 6-minute walk distance. So this medication just got approved in March, and it has a totally different mechanism of action, so it's kind of an exciting time to be in this space. So this is a current treatment algorithm from the most recent World Symposium that took place this past summer, where people who are at very high risk for hemodynamic decompensation, meaning that they have significant RV dysfunction, they're functional class 4, they've had repeated syncope, those people really should be treated with parenteral prostacyclins because, we think that there's a mortality benefit there. But if you're not high risk, then usually the approach is to do dual oral combination therapy. And then based on how people respond, and we need to reassess them pretty frequently, we might consider adding additional therapies like prostacyclin pathway therapies or sotatercept. So I guess also make the point that even though the definition has shifted to include patients with a PA pressure of above 20 as having pulmonary hypertension, we don't know whether those patients should be treated or not with medications because they weren't studied that way. And so the group consensus opinion was that we still should be using the cutoff of 25 and a PVR of 3 for treatment. And we need to investigate whether we should be treating people earlier or not. So that's how pulmonary arterial hypertension is diagnosed and it's treated. And now I wanted to, as I said, talk about a problem that's very prevalent in our geographic region, which is methamphetamine-related pulmonary arterial hypertension. So the first case of this was described back in 1993, where the authors described a case of a 33-year-old man who was a truck driver, which I think is a common reason to use methamphetamine so that you can be alert and awake. When he had a 10-year history of crank, which is another for methamphetamine, and peanut butter methamphetamine, which is kind of a mixture of stimulants use. And he presented with classic symptoms of PH. He had progressive dyspnea and syncope. His echo showed signs of pulmonary hypertension, so he did then get a right heart cath and had markedly elevated pulmonary artery pressures with a low cardiac index and a normal LVDP. And the evidence for this continued to mount over time. So this is a study, I think at the time done at Mass General, probably included Dr. Chanik as an author, who again is at your institution. And they looked to see whether the prevalence of stimulant use was higher in patients with idiopathic PH compared to PH with other risk factors or CTEPH, and found that about 30% of patients who were characterized as idiopathic PAH had a history of stimulant use, and that was much more in comparison to those with like connective tissue PAH or CTEPH, who were more on the order of like 4%, 4 to 5% had a history of stimulant use. And again, others have added to this literature. There's a really nice study out of Stanford by Dr. Zemanian, where they looked at characteristics of patients with idiopathic versus meth PAH, and they showed these are explanted lungs from patients who had those conditions, and they show that the patients with meth associated PAH had very similar vascular changes to those with idiopathic PAH, with the same proliferative lesions and ultimately obliteration of the vessels. And so methamphetamine was added to the list of known associated toxins that cause PH in addition to these other medications. Fen sort of being the first clue that amphetamines might have a relationship to PH. So now I think it's considered fairly well established that meth is a cause. And we don't fully understand why some people get PH when they use methamphetamine. I mean, there's a lot of factors that are hard to study, like, you know, the amount that people use and what else might be in the substances that they're using. But there is some work indicating that maybe some have a genetic predisposition to developing methamphetamine-associated PH. Again, this study came out of Stanford, Dr. De Jesus Perez, where they did whole exome sequencing from 18 individuals who had this condition and showed that 94% had a single nucleotide variant that was a missense variant and predicted to reduce carboxyesterase 1 activity, which is an enzyme that's involved in the metabolism of methamphetamine. And people with idiopathic PH did not have this variant. And so, yeah, the hypothesis was that if you carry this variant, you don't metabolize methamphetamine as well, and then perhaps you're more susceptible to developing PAH. And methamphetamine is growing across our country and in the world, and particularly in the Western United States. This is a graph of percentage of drug-related admissions from 2008 to 2017, and the West is in the green, so we're definitely having an exponential rise in our hospitalizations related to methamphetamine. We looked at our own patient population at University of Utah, and we saw that about 70% of our patients who have group 1 PAH had what we called associated PAH, so PAH from connective tissue disease or congenital heart disease or toxin-mediated. And then of those patients, about a third of them had toxin-mediated PAH. So a quite large percentage. And this is in contrast to other registries that have been published using data from centers across the country, like this one, the United States Pulmonary Hypertension Registry, including 15 different centers, where they showed, so about 50% of their patients had associated PAH and only 9% of that was toxin-mediated. So significantly less. We had 3 times more in our registry. And I think that's probably related to a couple of factors, including that methamphetamine use is more common in the West, but also I think it definitely exists on the East Coast as well, but I'm not sure the awareness and the screening is as robust there. In our practice, we screen everyone, and where I trained in Boston, I think we rarely screened anyone. So I think part of it might also be a detection problem. And there's some indication that patients with methamphetamine-associated PAH don't do as well as those with idiopathic PAH. So this is again from the Stanford group, their patient cohort, showing that patients with meth-associated PAH, which is the dotted line, had about a 25% survival at 10 years compared to idiopathic PAH, where the survival was higher. And there's a lot of use that might be related, but also methamphetamine is known to be cardiotoxic as well and can cause cardiomyopathy in addition to PAH. And it does this through several different mechanisms. Sympathetic activation, it causes prolongation of the QTC, and it also causes, it's directly cardiotoxic and causes fibrosis on autopsy specimens from patients with methamphetamine-associated cardiomyopathy. We can see myocardial death and fibrosis as well. And when we've again looked at our own population of patients with methamphetamine-associated PAH, we did a retrospective analysis where we compared those with meth-associated PAH and those with idiopathic PAH and kind of matched them based on their mean pulmonary artery pressure, which isn't perfect, but it was kind of a way of trying to hold the afterload constant between the groups, and then looked at right ventricular function on echo and found that patients with methamphetamine-associated PAH had echocardiographic findings of impaired RV function. So worse RV free wall strain, worse right atrial strain, larger RA volumes, an overall lower cardiac index, suggesting that there might be more RV PA uncoupling in patients with methamphetamine-associated PAH, and maybe part of that hypothesis is that part of that is related to direct cardiotoxic effects of methamphetamine. But as I mentioned, there are a lot of confounders in trying to understand this problem, and one of those is that patients with methamphetamine-associated PAH are treated differently. And that has to do, I think, with, again, sometimes there are psychosocial factors that complicate treatment, but also I think there is concern on the side of clinicians about sometimes the safety of using parenteral therapies in patients with a history of methamphetamine use disorder, and frankly, a stigma about the condition. And so I think those patients are less frequently offered this sort of gold standard or standard of care that patients with other types of PH are offered. And so in this cohort from the Stanford group, a significant proportion of patients with methamphetamine-associated PAH were not on IV or sub-Q therapy compared to those with idiopathic PAH. So that may also account in part for the difference in prognosis because they're not receiving the same therapies. And one sort of clue that this might be part of the explanation study is just, I think, an abstract or a poster, not a manuscript yet, but this group looked at 48 patients with methamphetamine PAH and 60 with idiopathic PAH, and showed that when they were treated similarly with sub-Q treprostinil, their TAB-C SPAP ratio on echo and their overall survival were very similar over a follow-up period of 53 months, so pretty good follow-up period. So I guess I would just want to make the case that, when we are thinking about whether to use parenteral therapy, we really need to, I don't think there's a one-size-fits-all approach. It shouldn't be a sort of blanket refusal. I think we have to individualize the decision and ideally engage addiction medicine, social work, but really our goal is to make our best effort to provide people with the gold standard of treatment. If we can, that's what we should be doing. So I did want to spend a little bit of time thinking more about what is the best way to manage our patients with methamphetamine-associated pulmonary arterial hypertension. And I think that includes, as we've talked about it, addressing toxicities of methamphetamine, so treating cardiomyopathy, treating pulmonary arterial hypertension as we would for anybody with those conditions, but also thinking about the substance use disorder at the same time in our general approach to patients, where we, should be striving for a non-judgmental approach using motivational interviewing, where we think about, are there pharmacologic or other strategies to help reduce use, and then prevention and harm reduction. So thinking about screening for infectious diseases and vaccinating against infectious diseases that people may be more at risk for. And then also harm reduction techniques like providing fentanyl strips and naloxone. So I'm going to touch a little bit more on those things in detail. So pharmacologic options for methamphetamine use disorder are more limited, but there are a few promising studies. So one is this one from 2011, where they looked at mirtazapine in patients with methamphetamine use disorder. So they randomized either to mirtazapine or placebo. Both arms got 30-minute weekly substance use counseling. And they found that the urine test positive for methamphetamine was significantly lower in the group that had mirtazapine. And overall, they also kind of engaged in less risky other behaviors that were associated with substance use. So that was a promising finding. And then this study, which was led by Steve Shopta, who's also at UCLA, looked at bupropion and naltrexone compared to placebo in patients with methamphetamine use disorder. And then anyone who was on placebo in the first 6 weeks that didn't have a response was re-randomized in a second stage of the trial. And they showed that, so on the left side is the group that received naltrexone and bupropion, and you can see that they had a significantly higher response, meaning decreased substance use compared to those that were on placebo. So 13% as compared to 1 to 3%. Still, 13% is on the low side, but it's still a lot better than 2%. So I think this was also a pretty exciting finding. And then people have been interested in whether using prescription stimulants may be helpful in amphetamine use disorder. This is a study from Sweden of about 13,000 people, retrospective study. And there was a signal that lisdexamfetamine, which is Vyvanse, was helpful in reducing the risk of substance use related hospitalizations. So maybe prescription stimulants are helpful as well, but I think that there is some hesitance to use them, especially in our patients with PH or heart diseases. We're worried about whether prescription stimulants may have cardiotoxic effects as well. I think the evidence there is actually pretty limited. I think there's some work from Stanford showing that there may be an increased signal for increased risk for pulmonary hypertension for people on prescription stimulants, but it's a pretty low increase in risk. All the same, I think people are worried to use those medications in that population. And actually, one of the more effective treatments for amphetamine use disorder is not a medication, but a behavioral intervention that was featured in the New York Times article that I'm showing you here. It's called contingency management, where people are able to draw from a fishbowl, and they can draw a card that has an affirmation on it, like, you're doing great, thanks for, good job coming to clinic, or it could have a $5 gift card, $10 gift card, or $50 gift card rarely, and you are rewarded for things like coming to your appointment or having a negative urine tox screen. And this is a meta-analysis of many different studies looking at the efficacy of contingency management, which I think shows a pretty compelling efficacy of this therapy. So this may be one of the best tools that we have for treating methamphetamine use disorder. And then, as I said before, I just wanted to touch on the importance of harm reduction, as well as we're thinking about treating patients with methamphetamine use disorder. So fentanyl is increasingly found in other substances, including methamphetamine, and many people don't know that the substances they're using include fentanyl. So fentanyl strips are a way to quickly check for the presence of fentanyl in drugs themselves or in urine samples. And this graph on the left is just to illustrate that the number of deaths in 2021 from opiate overdose was higher than that from COVID-19. So it's really a public health crisis. And interestingly, not only do fentanyl strips allow for safer use, but in this study where they looked at 93 individuals in Rhode Island who were using illicit substances and were given fentanyl strips, if they received a positive result, they were more worried about the possibility of opiate overdose. And so they had changes in their behavior, including safer use behaviors like consuming with others around, but also overall using less. It was kind of an interesting consequence of providing fentanyl strips to people. And then I think don't forget about naloxone, which is the rapid reversal agent for opiate overdose that we should be thinking about giving to our patients as well who have a history of substance use. So I really feel that the ideal scenario for caring for our patients with methamphetamine PAH is a collaborative care model where we are incorporating substance use treatment and we're incorporating specialty care. And ideally, if we can coordinate our care, it's better for patients, it's better for providers. And so we've really been trying to do this at our institution where we have our PH clinic and addiction clinic on the same day, and we're sharing patients, and it really enables, it's easier for their patients to get there, to see their doctors, and then also for us to communicate with each other. And this is a quote from one of our patients. I just feel like whatever issues are going on, they're all working together to help me do better with my diabetes and the addiction itself. So it's nice to have them, even when I'm not there, they're talking to each other how to solve issues or get stuff done. And so patients like it and providers like it too. And this was formally studied in the context of methamphetamine-associated cardiomyopathy for patients that had an EF of less than 40% related to methamphetamine use who are interested in cutting down or quitting. And they did a 12-week co-management program between addiction and cardiology at UCSF and included contingency management as part of that. And we're able to show some nice improvements in acute care presentations, as well as the number of cardiology visits that people attended. So on the left, in the 3 months before their intervention, the rate of cardiology visits attended was quite low at 15%, and the number of acute care presentations was high, 47%. During the intervention, the percentage of cardiology visits went up to 79%, which is really a marked improvement, and acute care visits went down to 20%. And then after the intervention, some of that did fade, although not completely. And I think in an ideal world, this is something that would be our practice all the time. But it was nice that they showed that it worked well. And so that's what we're, again, trying to do in our clinic at Utah, is have a multidisciplinary clinic. And we're also planning to study whether this works better than our usual model, by monitoring things like how much people come to clinic, and use, and also how they respond to pulmonary vasodilator therapy. So I'll end there by saying that we know increased pulmonary artery pressure is associated with increased mortality, but we have to think about the cause of that pressure in order to decide treatment. And PAH is a relatively rare disease, but methamphetamine is a common and frequently underrecognized cause of PAH. And I think treatment of methamphetamine-associated PAH requires a collaborative approach, which incorporates treatment of substance use disorders as well. And so with that, I will say thank you to my colleagues at the U. Salt Lake City is a beautiful place. And thanks to the residents who helped with our study, and then on the right is our PH group. So I'll end there.
Thank you so much for that wonderful talk. My name is David. I'm one of the second-year fellows. I was hoping I could ask a quick question.
Yes, please.
You had a slide earlier in the presentation about risk stratification of patients before starting therapy, and high, medium, and low risk. I was wondering if you could talk a little bit more about kind of the clinical factors that you're using to risk stratify people, and then what the clinical endpoints for treatment are. I imagine it's a combination of symptoms, RV function, and hemodynamics, but just kind of wondering how you look at these things when you're starting people on therapy and assessing response.
That's a great question. So there are a number of different risk scores that have been developed, that we use clinically. And so the simplest one that's pretty well validated, that was published in the most recent guidelines, is called the Compara risk score. And it's pretty simple. It just incorporates three things: the functional class, the NT-proBNP, and the 6-minute walk distance. And so the guidance is that we should be assessing people every 3 to 6 months. And if they're, and our goal is to get them into a low risk category. Low risk meaning low risk of hemodynamic decompensation or death. And so if they're not in a low risk category, that should prompt us to add additional therapies. I think the REVEAL score is also a commonly used score, which incorporates some other factors. But I like the Compara score because it's pretty simple and easy to do at our visits, and I think pretty predictive of how people do. So it's a good question.
Thank you. I had a quick follow-up question is, that one of the earlier slides also had those lower, the lower universal definitions with a PA pressure of 20 and a PVR of 2, and you have treatment thresholds that are higher than that. What do you do with those patients that fall somewhere in between, maybe with like a PVR of 2.1 and a PA pressure, mean PA pressure of 20? Do you just follow them and repeat hemodynamics when they get worse symptoms, or?
Yeah. Yeah, I think we don't really know what to do yet. And that is kind of our current approach, is to watch people over time and then start pulmonary vasodilator therapy if things get worse. But I think that's an area that people need to look at and are interested in looking at. Thanks.
Oh, that's a wonderful talk, Dr. Clapham. So I just have a quick question. Do you also have you mentioned the genetics in the beginning of your talk. Do you also have a polygenic risk score for pulmonary hypertension, or?
No, that is something that we exist currently. I think like I said, the majority of patients with heritable or idiopathic PH have mutations in BMPR2 or those other genes that I've listed. So have group 2 or group 3 PH, kind of trying to understand, are there genetic risk factors for developing precapillary PH, kind of quote unquote out of proportion to the degree of lung disease or heart disease or RV dysfunction. And so I think that would be an interesting question to look at, whether there are a combination of common variants that make some people more susceptible than others to developing those conditions.
Thank you. Okay, just another quick question. Do you also use the TGF-beta antagonist for your methamphetamine-associated pulmonary hypertension, or just no?
Yes, yeah, we have been using it, sotatercept and methamphetamine-associated PAH as well. It's still pretty early in its use. Like I said, it just got approved in March, and it took a couple months to kind of roll it out practically. So I only have a few patients that are on it, but I think anecdotally, I've been kind of impressed with how people have done, and also it's generally pretty well tolerated. It does require that you're able to inject the medication yourself subcutaneously, but you can do it at home every 3 weeks. And the main side effect is that it increases your hemoglobin. And then it also can lead to nosebleeds. And there's some concern it may increase risk for GI bleeding, but pretty rarely. But interestingly, some of the benefit of sotatercept may actually come from the elevated hemoglobin levels, because there was a sub-study of Spectra where they did cardiopulmonary exercise tests on patients on sotatercept and showed that their cardiac output really didn't increase. Their PVR did decrease, and then also their oxygen carrying capacity was increased predominantly through elevated hemoglobin. And then there were also changes in the periphery where people were more efficient at extracting oxygen. So it's working in more ways than I think we originally knew.
How much does it cost for patients?
Oh, it's very expensive. So current patients on it through that, or if their insurance doesn't cover it. And then actually we still have some ongoing clinical trials of sotatercept, so sometimes we can get patients on it that way.
Thanks so much, Dr. Clapham. It was an amazing lecture. It's fantastic to hear all about this. Really appreciate your time today.
Thanks so much for having me. Good to talk to you
Thank
guys.
you.